Hey everybody, it's Kevin and it's Donna, and welcome to another episode of the Med List. Really excited to have you guys. It feels like, Donna, we've been on almost a little end of summer break with vacations and everything in between. Breaks are good.
Absolutely. Yeah, vacations and Labor Days and things such as that. So lots of vacations and moves and everything else in between. So yeah, but hopefully we're back on track a little bit.
Yeah, I'm really excited. I feel like the one nice thing, I don't know if everybody listening kind of notices the same thing for themselves, but when you take like a little break or pause, like sometimes you have fresh ideas that come to mind, or you have fresh new takes on things. And I'm really excited to get a fresh new take on things from our next guest, of kind of looking at not the pitfalls in healthcare necessarily, like what are we lacking, but really what are we overutilizing? Where are the leaks in the efficiencies, of the boat that we're not plugging and making sure we're looking at. So I hope you guys are really excited to hear from her. I know that we'll cover a ton of topics, and it'll be great for both clinicians and patients. We'll talk to you guys in just a second. One thing I love to do, Donna, is the audience. I know you guys can't see it, but I can see Judith's face right now when she's off screen. And whenever people hear our intro or outro for the first time, like I can see their eyes kind of open up like, oh, wow, we're really going to rock into this. So without further ado, here's our guest.
Great.
Rock and roll.
Yeah, we love to have fun here too. Even though there's serious conversations, we do it with a smile and with a little bit of pep in our step. So today we have Judith Garber with us, and I'm so excited that you're here with us, Judith. Judith is a senior policy analyst at Lown Institute, a nonpartisan think tank based in Boston. She's co-author of several Lown white papers on topics such as medication overload, overuse in U.S. hospitals, hospital community benefit investment, and health spending in state budgets. Her work has appeared in Stat News, The Hill, Health Affairs, Modern Healthcare, Center for Healthcare Journalism, and other publications. Judith also has a degree in her master's I missed my spot here, from the Heller School of Social Policy, and also a BA in American Studies and Political Sciences from Rutgers University. So thank you so much for being with us, Judith. We're happy to have you here and to learn from you.
Thanks so much for having me. It's great to be here.
Oh, we're so excited to have you. And I think that, before you jump into what is a senior policy analyst, for us all to understand and get an idea of what a think tank is doing for American healthcare, you got to tell me more about your ultimate Frisbee background, because that is just too much fun. And for all those out there, you can have things outside of your vocation that you really enjoy to do. Ultimate Frisbee, too much fun for the folks that haven't played it before.
I could talk about Ultimate pretty much all day. I've been playing for about 20 years now, which is awesome. Really fun because I will sometimes go to tournaments or pick up and see play against 20-year-olds who are just running up and down the field. Like I say, I've been playing Ultimate as long as you've been alive.
That's great. I love
when did you start and why'd you get into it?
Say that again, please.
When did you start and why'd you get into it?
I started in high school because we were one of the very few high schools that actually had a program. And I think I had played it at summer camp. I was like, this is fun because I wasn't super athletic, but it didn't seem like it was going to be very serious because it's sort of a hippie sport. And then I realized, oh my gosh, there's a lot of running involved here. I better start learning how to run.
I played a little bit in college, and it was, I don't know how to describe it, Judith. Please correct me if you think this is a bad description, but I thought if you put flag football and Frisbee together, that would be a way that I would think of general audience understanding Ultimate Frisbee, but a ton of fun. And you just don't see that on very many profiles that someone loves Ultimate Frisbee, which is so cool. Any other takeaways from that before we have to unfortunately get serious?
Oh, just, I don't know. I guess Nationals is next month. Go watch it. It's fun. So much fun to watch.
Oh, super fun. Well, I love that plug. So the next piece, I think, Donna, though, is just for us and general audience, those that haven't encountered a senior policy analyst or what someone from the Lown Institute would be doing for them or impacting them. Can you describe that to us, Judith?
Sure. So, we have a very small team at the Lown Institute, but we have maybe like there's 15 of us, and we have a data team that works a lot with Medicare claims, IRS data, all other types of data. We also have a communications team that works on putting out all kinds of blogs and reports. And I'm sort of at the intersection of those two teams, sort of helping with both sides of interpreting some of the data and then translating that into communications for a variety of audiences. And also thinking about, I think for almost all the blogs that we put out usually a couple each week for free at lowninstitute.org. For each of these blogs, I always try and make sure we have some kind of solutions in there, and whether they're incremental or systematic, having that in really, really helps.
Oh, that's super helpful. And I mean, looking at, I'll pull it up, Donna, when you kind of ask the next question, but looking at some of the things that are put out by the Lown Institute, everything from cancer screening costs that I'm seeing to Medicare Advantage plans and how they're changing and the overdiagnoses that we're currently seeing. But Donna, go ahead in. I know you have lots of questions for.
Yeah. So I just really want to start off with, sharing with us what the Lown Institute is and how did overmedicated and overuse type of topics abound from this think tank.
So the Lown Institute, we're an independent think tank. We advocate bold ideas for a just and caring system for health. We were founded by Dr. Bernard Lown, who passed away in 2021 at the age of 99 years old. But he was a pioneering cardiologist, inventor of the direct current defibrillator, also leader of a anti-nuclear war group that worked with doctors both from Russia and the US, which he was attacked a lot for at the time because, Russia was the enemy. But he persevered and won the Nobel Peace Prize during the Cold War for that. But he was a huge proponent of avoiding overuse. His motto was do as much as possible for the patient and as little as possible to the patient. So in cardiology, overuse is pretty rampant. So it was good to, he was really in favor of listening a lot to patients and figuring out how best to help them without unnecessary surgeries and things like that.
Mm-hmm.
So when polypharmacy, that was a rising issue among older adults, still is. So we're really happy to get a grant from the Gordon and Betty Moore Foundation back in 2018 to study that in depth. And we created both sort of a framing paper and an action plan around that topic.
Yeah, which I know was very influential for me. And as you know, Judith, you provided a testimonial too for MedStrong. So thank you for that. But really instrumental in helping people, both providers and patients. And what I love what you're saying previously is how you try to pivot that information so that many can understand. It's not just for the medical world and it's not just for the health consumer world. It really crosses both and really educates and provides information and solutions for both parties, if you will, or all entities. So I do love that about the material that I've read. I think it's very comprehensive and just easy to flow and to learn from. So I do love that about a lot of the information that you provide. So
I'm so happy you brought this up. I love this comic.
So beautifully done. For those that can't see it right now and are potentially listening on one of the podcast stations, I pulled up something from the Lown Institute that they put a little cartoon together that there is a little pill that is saying, hey there, I'm the medicine that'll make you feel better. And then he's joined by another little pill that says, and he's going to give you diarrhea. So I'm here to help with that. Another pill comes in and says, both these guys will make you anxious and depressed. So I'm here to help with that. And then finally, a fourth pill comes in and says, did somebody say erectile dysfunction? And so I feel like that's so perfectly done and comical in so many ways. But tell us, Judith, when you were doing your research, and kind of looking at this, how often did this kind of thing come up, that this was a very real problem with the patients that you're looking into? And how did you go about the research to be able to uncover more issues inside of polypharmacy you mentioned?
Yeah. Well, I do want to give a plug. We didn't create that comic. That was there's a talented artist who created that, who we give credit for in the piece. So, but yeah, we wanted to really explore a lot of the angles around polypharmacy. You know, how prevalent is it? And that got actually complicated right off the bat, because there's no necessarily like a definition of what is too many medications. Usually polypharmacy is 5 or more medications, but 5 is kind of an arbitrary number for what is considered a lot. I think I've seen a label of extreme polypharmacy or like ultra polypharmacy is 10 or more.
Hyper polypharmacy is, yeah.
Hyper
Yeah.
extreme.
I share that with my students regularly.
But there are so many different definitions, and sort of parsing through these definitions, as well as looking at kind of the impact, what kind of adverse events are associated with taking multiple medications, and sort of also sorting out the differences between polypharmacy or using multiple medications where it's indicated and appropriate and it's beneficial, in the cases where it's really causing harm. And the comic that you showed kind of shows one very common way where that happens, where it's like the prescribing cascade, where one thing leads to another thing. And we have a story actually in the report from someone that we were working with, who worked with us on some of our advocacy issues, where her husband, who had Crohn's disease, was taking a variety of medications, but each one was causing such horrible problems that he eventually, I think, was on something like 30 medications at the end of his life, and they really destroyed his quality of life.
Mm-hmm. For sure.
Entirely.
Yeah. So just to, I know we want to talk about some other topics too, but just to talk a little bit more just about this over medication. After this framing paper, I believe that you call it, comes out, eventually you end up with a national action plan. And are you able to see movement post these plans that you put out? Like, how do you guys continue to work through, like, here we've put this forth, and are people actually doing this? And in what areas are we seeing movement? And has there been any improvement or any take up of some of these actions that you guys are proposing?
I think so. After we put out the action plan, at the same time as we were doing that, there was a lot of exciting stuff happening sort of in conjunction with what we were doing and involving a lot of the folks that we were working with. So the Deprescribing Research Network took off around that time, and they have done fantastic work in funding research, providing grants, tools for investigators who are doing work on deprescribing. So I've seen just so much more research now on the topic, at least in the US. Deprescribing Network in Canada keeps doing fantastic work as well. And I think some of the most impactful solutions, I don't know that they've really, like, something like getting rid of pharma funding doctors, paying doctors for speaking and food and all that kind of stuff that we know does correlate with prescribing. Things like industry, direct-to-consumer advertisements and that kind of thing. That's not going anywhere, unfortunately. And I'm not sure. I have heard a little bit about a lot more deprescribing trials going on. And I know that there at one point were some payers that were looking to implement medication reviews. What we saw. So I think that's happening on maybe a slower rate. So.
Yeah.
That makes perfect sense. I think the one thing I'm curious on, just kind of looking through here, the deprescribing elements and the polypharmacy components, we've talked about, I'm sure, I don't know how many guests, Donna. I'm guessing every one of our guests, we've probably talked about that topic. But one thing that we haven't touched on, Judith, as much, that you're really showing a ton of expertise inside of the space, is when we're looking at the value, like the pharmacoeconomic value of bringing in a new drug and or treatment and the value it's bringing to society, I see that there's, one blog post that's talking about the Alzheimer's drugs. I just had patients reach out to me, actually multiple patients just recently, talk about, hey, I'm considering going and getting this new infusion for Alzheimer's for a family member. What do you think of it? Where's the data behind it? Is it worth it? Those kinds of things. When you're doing those assessments, Judith, and just both for clinicians and for patients, how do you do those assessments to see where the value or the return on investment is for these new therapies that are so expensive?
That is really tough. And I usually rely on groups like ICER, Institute for Clinical Economic Review. They do cost effectiveness reviews of medications that I think is really fantastic. I think it depends, for Aduhelm, that one was almost easier to communicate about because there's no evidence that it actually works. You can say it's not worth it. Now we've got some new, they're also, affecting the amyloid as well. And I think what I like to communicate with is the way in which this doctor a while ago was taught, sort of put it into terms of like using a decision theater, like out of X number of patients that take this, how many will benefit, how many will suffer a side effect. And I find that that's a much clearer way for me to interpret it. And often that also resonates with a lot of other people about that. Maybe it is a little tough too, because when you think about cost to Medicare, that's something we're all paying into, and you do have to pay a copay of that for Part B drugs, but it may not seem as like, oh, I'm not paying that. So why not use it? And then one thing I've seen to sort of that opens people's eyes about that is like, well, if everyone who was going to be taking that drug, that was eligible to take the drug, took it, what would the cost be? And it's insane. And it's the same thing with the GLP-1s. That one's trickier because, what are the downstream savings on people being healthier? So I think that has to be weighed. But a lot of the things in terms of the drug prices, which is very related to value, the prices are just set by what the market's going to bear. So, yeah.
Wild to think, I think, with that statement right there, when it comes to the GLP-1s, so Ozempic is an example for those that are listening, the pricing that happens inside the United States versus the pricing outside of the US, and what kind of economic burden that puts on the US healthcare system when that is so much more inflated, in the hundreds and or thousands of dollars more than other nations are paying per vial. The other pieces that are really interesting, I did see one physician comment this way, and I really love it, is we also have to look at what's the opportunity loss, that we're having here. So they're saying, great, like we'll need to treat a lot of individuals and there's a lot of upfront costs, but what costs are we avoiding for those individuals that are not going to make lifestyle changes, to the healthcare system in general? When you're doing these kind of things, Judith, I have to ask this. You're putting in so much work and research time in general. When you're evaluating what kind of societal impact is being made by the work that you're doing, like how does that happen for your guys' team? I'm sure, with grant work, you're trying to fulfill the needs of the individual grant, put a publication out there that's solid and has a high read rate. But what are some of the other ways that you like to make sure that what you're doing is very meaningful to policy and influence when it comes to private and public payers?
Yeah, I mean, almost my favorite measure of success with like when we put out any kind of press release or report, and we'll get a certain amount of media attention. But if I can get, or if we as our team can get a meeting with the Senate Finance Committee, with the Ways and Means Committee, with something like that, with CMS, with CMMI, that is like, to me, the biggest measure of success, that folks want to know more about what we're doing, because policymakers want to know what they can do. And that, I think that's, that's been some of the most rewarding things to see out of what we put out.
Beautiful. I love that.
That's great. So kind of back to what you were talking about with some of these studies, and we do know that there's a lot of studies coming out right now that Alzheimer's can be prevented too. And there's a lot of this intense lifestyle that is being put forth as well. And it's very prescribed amount of lifestyle that in what needs to happen between particular foods and particular exercise and socialization and many different things, even counseling or maybe some speech therapy kind of assistance. So when you're looking at this and weighing it, I know we're a society who loves, let's just try med versus let's try all this really hard work. Do you what is that like for you as a think tank when you know that there is this great stuff that people can do for themselves? How do you put that forth so that you empower people versus, you know, what I'm thinking about too is if there's this overuse, right? If folks are having over medication or over testing or over whatever it might be in the healthcare system, how are we empowering the patients to go, you know what? You can make a difference, even like a small change at first and then add on to it. Are you able to do that in your work, or do you see that evolving?
That's a good question. I think when we look at some procedures or things that are overused, we do see, alternatives that are recommended. For example, we're looking at overuse of spinal fusion for low back pain, and low back pain is such a huge problem. I think it's like the most common kind of pain that exists in the world.
Mhm.
I'll look at I think it's globally such a huge problem. And it's really hard because we don't have a cure for it, but there are some things that can help. And I think there's like, when it comes to certain kinds of low back pain, these procedures are not necessarily recommended as sort of what the first line of treatment should be. And there's actually recommendations of trying physical therapy first, and that kind of thing. So I think there definitely are, recommended alternatives that happen. I can't speak on any of the things about Alzheimer's though.
Yeah, no, that's fine. But just in general, like, so say for example, somebody is just going and seeing a doctor about something new, and they're going, okay, does this make sense? How do I know as a healthcare consumer whether or not I'm overusing healthcare? Like, oh, they want to check this, this, and this. We think, oh, they're being so thorough because they're doing all this testing. Is there some red flag that we should be considering as healthcare consumers to be like, whoa, wait, this seems like it's overuse, or how do I check? Or
this is a really interesting thing, because for the most part, people don't know that overuse has necessarily happened, and they usually often perceive it as great care because look at all the things I got, unless there's a complication or something else happens. But I think for me, I can just speak from personal experience. I had an issue, like an unexpected symptom. I went to the doctor because I was a little concerned, because of course I went online like you're not supposed to do, and it says, oh well, probably something bad. I'm like, okay. So I go to the doctor and I tell them about what's going on, and they immediately want to do some tests. And I had asked, like, well, so what are you testing for? And they didn't tell me. And at that point, I was kind of in the machine and it was going, and I didn't really know how to stop it. And so the test happened. It was uncomfortable. It didn't tell me anything. And I think looking back on it, I really wish I had said, but can you tell me sort of what are you looking for? What are the options? What could this be? And what are your ways of thinking about it? They said, no, the next step is we're going to do this. And I think it's hard to not. But I think just asking simple questions about what are we testing this for? And I've actually sometimes used this in other cases, just a little while ago, for like lab tests I was getting. I was like, okay, so what are we getting this for? And they explained. I was like, okay, well, that seems reasonable. So there's just I guess feeling empowered to ask more questions, which can be really hard in when your visit is limited to 15 minutes with your PCP and they've just come off their 7th visit of the day. It can be so hard.
Yeah, for sure.
It's so interesting that you mentioned that, Judith, because we're seeing more and more often that there are messages like post-visit that we're using messaging systems to be able to get a hold of our providers because we're going, 1, all my questions weren't answered. 2, that wasn't clear and I need more explanation on what's going to happen next. Or 3, I'm not comfortable with what we discussed, as comfortable as I thought I was during the moment when I just kind of got pulled into the machine. I love that phrase. I'm going to steal it from you. But you get pulled in the machine and the cogs start rolling and you're just stuck, right? What's next? But we see examples, Donna, you can add as many as you'd like to as well, but PSA screening. So looking at prostate cancer, right? Us going overboard on that and us having to have guideline influence to say we need to pull back on how often we're screening. When it comes to UTI, we were over screening individuals and giving them too many antibiotics. You guys just put out an article more recently when it came to cancer screenings, though, Judith, in general. And I'm really curious to hear some of your thoughts when it comes to cancer screenings, because there's a massive expense right inside the United States. When it comes to oncology, prevention is massive. We want to make sure we're catching things early as often as possible. There's also big drivers that maybe folks don't understand that I'd love for you to get into when it comes to some facilities are staying open and they're making money on colorectal cancer screenings, right? Colonoscopies can be a big driver of revenue. And so seeing some of these new technologies go into place where we have stool samples and or blood testing that are maybe moving away from those previous screenings. There's some arguments, obviously, when it comes to overall comprehensiveness, but I'd love your thoughts on, that article and your thoughts on cancer screening in general.
Yeah, this was something I really didn't know a lot about at all until I came to Lown Institute about 8 years ago. And I think the general view of cancer screening is that it's the responsible thing to do for your health. It saves lives. And what I like to say is that cancer screening, this also, I will preface this really depends on the type of screening and the age at which you're screening. But cancer screening does save lives, but it doesn't save near as many as you might think it does. I was really shocked when I sort of looked at the U.S. Preventive Task Force comes out with their sort of modeling studies and their evidence, and there's the number of people that avoid death from breast cancer from a mammogram is so much lower than I thought. And a lot of people, you can still get a mammogram and still unfortunately die from breast cancer. It's really sad because you think this is what I'm doing for my health. But I was surprised to see that the likelihood of having your life saved by a mammogram is way less than your likelihood of getting a false positive or having an unnecessary biopsy. So that's something I do like to get across. It doesn't mean that we should in any way, we have to do away with screening. Absolutely not. But I'm really excited by the efforts to target cancer screenings to those who are at the highest risk. Because really the issue with screening is that when you do something to everyone, regardless of if they have symptoms or not, then the likelihood of getting a false positive is much higher than getting a true positive. So if you can better target folks that are at a higher risk, then you're more likely to actually identify real positives instead of false positives. I think that's a good way to go.
Judith, I think something too, so this is a topic that comes up in the U.S. healthcare course that I actually teach, and when we talk about some of these screenings and who's to decide kind of thing, and how comfortable would you be, right? If it's you, and I ask the students this, how comfortable are you or not having your parent, your mother or an aunt or, sister go to have these tests to be done, especially for breast cancer and cervical cancer. And so, we talk about that. But then on the other side of it, like you're talking about the false positives, there's also this anxiety that comes through, not only for some people going to have these tests in itself. And then if there is a false positive, that is so anxiety provoking for people as well. And it just seems to kind of put you in a whirlwind and a spin. And that can be detrimental to a healthcare, protocol too, because it really is getting people worked up beyond what they need to be. So I think that getting that information out and saying, even what is the numbers of false positives and how don't worry until you have to worry kind of thing. And I hate to say it like that, but there's some type of necessity for that with the protocols that are put in place, I think.
There was like a recent article that just came out maybe like a week ago or a couple of days ago about women who got a false positive mammogram were less likely to have subsequent screening. And among the women that had to get, I think, had to come back for follow-up or something, it was even lower. And I think that's a part of the harm of overuse we don't talk about a lot, is like losing trust in the healthcare system. We I think we had like a group get together. This is pre-COVID, so I don't know what year. Just pre-COVID, in the before times. We had a group together to talk about overuse harms and think about like, what are we not talking about here? Because we have, physical harms of complications as well as cascade events, but there's also financial harms from the cost, from out-of-pocket costs. And then there's these social harms of what, like you said, like the time it takes to go to the doctor, getting childcare, getting away there, all this stuff, especially if you have to go back for follow-up things. That's something that we don't really account for in the cost. And then the trust issue, I think, is something we don't usually account for.
Yeah.
Those are great points. Yeah, I feel like there's a lot of personal stories that I can think of, Judith, and I'm sure we all can, when it comes to family members being impacted by that exact same roller coaster ride. What is the best thing to do for your family and for yourself overall? The one thing that I'm curious to know more of is when it comes to the healthcare delivery process, and you mentioned like getting childcare. Well, some people can't afford to get childcare, right? And so like, what's the next step for them when it comes to some of those economic shifts? And I'm getting ideas just from your articles, which are fantastic, by the way, but it's really looking at our rich folks at a higher economic class getting better care, overall, is one of the articles you put out more recently. And how much low value care are they getting? Did you want to describe that a little bit? Because some of the things in here, Donna and audience, that are really delved into is antibiotic use. And are we using things like benzodiazepines for depression? So things that we typically wouldn't want to see in our patient population. Is that a change for economic status if you're getting that or not? But Judith, the floor is yours. It's your article.
Yeah, I'm going to have to pull this one up because even though I wrote it, sometimes I have to go back and look. Yeah, what I remember from this is that it really depends on the type of low value care we're talking about. And I think antibiotics is a big one because it's something that I think most primary care doctors know is not helpful for colds and respiratory viruses, but almost the perception, like patient perception of I need this. And but I also don't want to just say, I don't want to, blame the patients here. I also think that this is like, it could even be provider perceptions of what they think the patient wants. And especially if that patient is wealthier and you perceive them as having more power and, maybe you're giving out the antibiotics more. I think there is a good amount of kind of personal, like personality factors when it comes to these relationships and overuse, which I think is really interesting. Yeah. And this is based on a study by Doctors Park and Wadera that was in Health Affairs a couple months ago.
Okay. Yeah, it's really interesting tidbits inside of there. I mean, I'd love to get some thoughts from both of you guys on a few of them. I mean, and one is this one here that looks like one of the most like stark contrasts between high and low income. So low income in your green/blue, middle and the orange yellow, and then the reddish color is high income. But this one here, Donna, jumped out to me. Opiates for back pain. Like, how often are we going directly to opiates being used for back pain as opposed to other modalities that can potentially be leveraged? And I think it's fascinating to see how like how much of a difference, almost a twofold difference from high income individuals versus low income getting those types of treatments. It can be very problematic for several reasons. Yeah. It brings me to another thing that we talked about before the show started. When we're looking at what hospital systems, because you guys, all the folks listening, probably realize that you hear healthcare is struggling, right? Your hospitals are struggling. They're not making money. The margins are thin. There's less clinicians than we actually need. And that's true, but it depends, right? I mean, that's really the economic case in almost everything is it depends. I feel like I should have a stamp or a sign in the background that says it depends. But if you're in a more affluent area, an article recently kind of talked about those hospitals that are targeting these areas that are wealthier and they have better payer mixes, meaning that there's more private payers that are being leveraged as opposed to Medicare and Medicaid, are doing better. Like they are profitable. Their margins are actually quite decent. And there are certain hospital systems that seem to almost target those areas on where they're going to put something, almost like a thought that you'd have with real estate. I'm going to invest in areas that are location based, or as the individual I was watching, Dr. Eric Bricker, shout out to you, restaurants. You want to put a restaurant in an area where there's good foot traffic. It's going to fit the individuals that are in the area. So when it comes to evaluating hospital systems, Judith, which I know you've done a lot of work in recently, give us some of the epiphanies that you've kind of come across when it comes to quality of care, overutilization of care, all the pieces that you've kind of rocks you've overturned.
Oh my gosh, there's so many rocks. So just a plug. So what you're referencing is our hospital ranking called the Lown Hospitals Index. And you can see all rankings for more than 3,000 hospitals in the US on lownhospitalsindex.org. Oh my gosh. I think one of the big ones is this we see an inverse relationship between a lot of our measures of health equity and a lot of our measures of health outcomes. And so for us, that has shows two things. One of the things it shows is that a lot of the highest, most prestigious, kind of known to be high quality institutions, hospitals in the US, a lot of those are really inaccessible to low-income folks and often to communities of color. And the second one is that a lot of the more accessible hospitals, because they don't have, like you said, that payer mix, that means you're on a lower margin. That means you have less to devote to quality improvements. And there's a lot of demonstrated disparities in health outcomes that have to do with what hospital you're going to. And if the hospital that you're going to that's like the closest one to communities of color has worse quality, that means that's just perpetuating disparities.
For sure.
That's super interesting. I was just looking through the index right now, and one thing that Dawn and I are very conscientious of is just what is the cost of going to this institution, in general, like if there are some comparative aspects. And interestingly, your guys' ranking, it doesn't equal cost, because some of the highest ranked individual institutions here are also known as some of the most expensive institutions when it comes to margins and markup. So give us a little bit more of a breakdown on these indices and how a listener would potentially use something like this, Judith.
Yeah, I will say that we have a lot of different metrics. So if you go to our rankings hub, I would say go choose your state and then check out any of the metrics that interest you. We do have a lot of overuse metrics that are based on Medicare and Medicare Advantage claims. So that really shows, let's see, what are some of the ones we have? We measure 12 overuse services, including stents for stable heart disease, back surgeries for low back pain, imaging for fainting or simple headache. I think we have low value colonoscopy also on there. So definitely take a look at that if that's something that interests you.
Yeah, super interesting. I'm literally pulling Washington State apart right now and looking at the critical access hospitals that are on there, which is really nice for us that are out in the middle of nowhere and need to get care and want to see how good that care is. It's being delivered. And the exact same thing when it comes to my interest in just general hospital systems and the acute care offerings here. It's nice to know that my Spokane hospital systems that are in the area are ranked quite well, but also really interesting to see some of the critical access hospitals also ranked very well amongst them. And looking at those, how would you break that down for someone if they're going into, I'll just pull it up, Judith, so we can do an example, let's say. And I've got share screen. Here we go. So if I'm looking, I've got some colleagues that are in this area at Whitman Hospital, which shout out to Justin Ross and the rest of the crew down there in Whitman. But looking at how this is broken down for a viewer, if you're in the Colfax area, how would you look at this and pull this apart and be able to see this as an individual that's in the area thinking about taking care from Whitman?
Yeah, so you scroll down a bit here. So social responsibility, that's one at the top. That's sort of a composite of the three main categories that we have, which is equity, value, and outcomes. And we have equity first, which basically just shows to what extent is the hospital serving its community. Community benefit is about free care spending and spending on other types of community health programs. Pay equity is CEO pay, but compared to your housekeeper wage. Inclusivity, this is a really interesting one where it shows the extent to which the patients who could come to your hospital actually do, and in terms of location. So like, let's say a lot of folks come from a zip code that's like 5 miles north, but none come from 5 miles south where it's a poorer area. You'd probably get a lower score on inclusivity. We talked about avoiding overuse. And cost efficiency is actually a measure of our outcomes compared to total Medicare costs. And then these outcomes ones, we have, I don't know why. Oh yeah, clinical outcomes, patient satisfaction. Oh yeah, critical access hospitals didn't have patient safety data because CMS doesn't collect it. But the patient satisfaction, that's from the HCAP survey from CMS. And the outcomes measure is a measure of like all patient risk-adjusted mortality, and there's also readmissions in there as well.
Amazing.
So when you're looking at these hospitals too, doesn't it also depend upon one's insurance too, as to where they go? So for example, there are, depending upon, which is the in-network or out-of-network hospital, that is going to matter for where people are going as well. So how much does that influence what you're seeing with these scores?
Well, what's fascinating is like almost all of this data is just Medicare and Medicare Advantage. Mm-hmm. And so, well, to the extent that Medicare Advantage has limited networks, definitely. But one thing that's interesting is that when we were first looking at like elements of like income inclusivity and racial inclusivity, we were kind of expecting to see like not huge differences because it was Medicare. Mm-hmm. But even in the Medicare population, there are differences in some cities. And a lot of it is based on kind of historical residential segregation being so strong. But I think some of it is also because if you previously had Medicaid and there were certain hospitals that you felt welcomed at and others you didn't, once you get on Medicare, you still might go to the hospital that you felt more welcomed at previously.
Sure, for sure.
That makes total sense.
Do you find that, and I'm not certain how deep this information goes, but I'm assuming that there is more overuse with people who have, let's say, the platinum insurances versus those with bronze insurance. Is that it? So people who are paying higher premiums and lower cost per event, shall we say, or getting full coverage if they're hospitalized, if they have to be seen, or very low co-payments, are those the heavier users? It's almost like that income like we were talking about, but in general, do we see more overuse because people aren't necessarily having to pay out of pocket or think about, oh my gosh, what am I going to get in the mail for for a lab on this, or if I am hospitalized, what am I going to end up having to pay? Mm-hmm. So are you seeing that?
Yeah, I think I don't know like the exact answer to that. Mm-hmm. I think it's related to what we see in the study about like related to income, do people get more? I think it depends, because like, even if I have like a large amount of cost sharing and I know I'm gonna have to pay a huge chunk of whatever I do, I think to a certain extent I'm gonna be like really discerning about what I get. But also, if a doctor tells me I need this, I'm gonna probably get it anyway, and I'll find, people will go on GoFundMe and find something to help. So like, I think that works to an extent, but a lot. Sorry, I got an echo there. But I think a lot of it depends on how fruitful the conversation is between the doctor and the patient too. And I think to a certain extent too, like the more cost sharing you have, like you're more likely to also avoid needed care, right?
Yes, absolutely.
So that, I don't know if there's really a discernment between, I think there's this idea that, oh, if we, give patients skin in the game and all that, then there will be more, that people will be more discerning about trying to avoid overuse. But I think it's more like you just avoid all care, whether it's overuse or whether high value or low value. That's sort of something we saw during COVID a bit, where like we did look at sort of hospital overuse during COVID. And I mean, this was probably pie in the sky, but there's the idea of like, oh, well, when COVID hit and everything was shut down, like it literally shut down everything. But then as things started to open up, there's the idea of, okay, we're still at pretty high risk. Probably no one's going to be doing unnecessary surgeries and stuff at this point, right? In like, the summer and fall of 2020. But like once things opened back up, kind of the rates of overuse just went right back to where they were, because I think maybe folks don't perceive it as overuse. It's just sort of business as usual.
Yeah.
Yeah.
So question for you, and I'm just because you mentioned the Canadian Deprescribing Network and the US Deprescribing Network, and knowing that you have some understanding of other international health care systems, do you think that there's more overuse in the United States because we have this individualized healthcare system versus a national healthcare system? Do you think that that makes a difference on overuse within the systems? And I know this is beyond maybe what, yeah, I know you're doing a lot of everything that you do in the United States, but just because you did bring up Canadian Deprescribing Network, I was just curious how much you looked at other countries.
I would have to go and like actually review some of these studies to give you like a factual answer. I do remember something like when we had conferences, there's overdiagnosis conferences and overuse conferences like around the world. To me, I know that single payer doesn't solve everything, but I do think that being more resource constrained does put pressure to like really make sure everything you're doing is, and I think also like if Medicare does measure low value care, but they're having, and I know there's value-based models coming along as well, but I think like if Medicare covered everybody and that becomes an enormous cost, there would have to be a really strong efforts to like really make sure that it was only covering things that were really truly necessary. I know that in Canada too, though, I don't believe that the single payer system covers prescription drugs. So I think that is
only certain ones. It's a standard.
Yeah.
Yeah. It's not all drugs for sure.
I think there's something about, I think the payment model makes a big difference, but I also think that the culture makes a big difference. And I think it's really, really hard to deal with uncertainty if you have someone who like is dealing with a symptom and you want to give them something to help and you want to also like ease their mind. It's really hard to not do a test. And I think that's true regardless of wherever you are, if you're a doctor anywhere.
Yeah, there's some really interesting data on the conversation you guys were just having that I've seen of late. One is that those that are non-specialists when it comes to the referral process will oftentimes, if it is what's the appropriate word today, Donna? Let's just say it's a provider that is not a physician, whatever we're calling the mid-level world today. The number of tests oftentimes will be greater that comes from mid-level providers. There's some data on that. mid-level providers, correct me if there's newer data that's showing something different. And the exact same thing, I saw a recent study with Taiwan, once again, something very similar to Canada and the UK with their centralized healthcare system. The number of visits that they have per year, significantly higher when they're utilizing the healthcare system. And so when it comes to what their outcomes are, it's really interesting because the article wasn't actually about their utilization. It was about the lack of clinicians in a given country and how they're really struggling at that level of demand. And so I'm curious, we're talking about the utilization of a healthcare system. Today, I think the biggest struggle, Judith, that you're probably seeing in some research, and I'm sure hopefully you're getting some grant funding to look at it, is we don't have enough time to be able to see patients. I've talked to some folks that are specialists and they're saying, I'm 6 months out. And so if you have a specialist diagnosis and you're concerned about what am I going to do with my life between now and that 6 month period of time, that's something when it comes to healthcare utilization, overspending, overutilization, that really hits a brick wall of, I can't even see a provider, let alone get them to overspend or utilize on me. Thoughts there, Judith?
Absolutely. Well, I'm a huge proponent of universal healthcare. And so it always bothers me when people talk about wait times. And I'm like, you don't think we have wait times now in the US? So I don't know, as if we can see any doctor whenever we want to now, which is not the case. I hope that, I think that part of it is continuing that pipeline for clinicians of all for nurse practitioners and doctors as well, but then also making sure that they don't get burnt out. And because then I can't imagine just seeing so many patients every day for just 15 minutes each, and then feeling every session as if you didn't really quite get a chance to help everybody, and now you're late, and it's a very stressful existence. And then you're in your pajamas doing billing and coding every night. I don't think that's what most people sign up for when they want to become physicians. And so if that's going to be sort of the work environment that we generally expect physicians to do, I think people are just going to leave a lot sooner.
And they are. Yep. We're seeing it in unfortunate droves. Donna, any last questions for Judith? Judith, wonderful job. You've really covered so much ground.
I know. There's a lot.
Thank you for the great question.
But so I just, I think we just want to wrap up in regards to know that people are over medicated. We're overusing healthcare and we're overspending potentially. And so really, like you said early on in this discussion, Judith, is to ask questions, right? Don't just be okay. Ask questions, especially if you have the opportunity to, and say, wait a minute, like you said, what is this test looking for? Why are we doing this? Or what would this procedure do? So I want to share that because that's such a key component of what we talk about is being empowered to ask questions. I don't know if there's anything more that you want to say in regards to that component for patients and or providers.
Well, yeah, another question that I picked this up from someone. I did not make this up, but like, what happens if we do nothing? I've asked that many times, and sometimes then the answer I get is like, well, I guess I need to do this. But I think having that question answered can provide a lot of clarity one way or the other. If you're sort of struggling with whether whatever you're being offered or whatever you're looking to get is something that's worth it as well. And I think something for on the provider side, I think we've talked a little about like sort of the relationships between providers and patients and how it has to do with personality. And sometimes you have a quick session, so you don't have time to maybe have a huge conversation. So then maybe doctors might assume like, oh, this patient doesn't want to deprescribe any meds, or there's an assumption that patients want more because it is the dominant culture of more is better in healthcare. But not everyone feels that way. And it's important to sort of understand what are the values that everyone is coming into this with. Do they value being, doing as much preventive things as they can, regardless of sort of the balance or, which side of that scale do you land on, is important to know if you want that next test or that next drug or something like that.
Perfect. Yeah, I think that there's a lot of them out there, but there's Kaiser. I've used some of their like test modeling or their question like prep. One nice thing that Don always hears me talk about is you can use something like an LLM or a chat GPT to be able to help you when you're going in on what questions should I be asking, when it comes to this. But here's some things that, are kind of posed in general from Kaiser when they talk about medical tests. And I do love that, like, what is it basically? So now I can do my own research when I go home to get a better idea. Like, what is the reason that I need it? What might happen if the test is delayed? Just like you were saying there, Judith, how accurate is the test, right? So we talked before, Judith mentioned like number needed to treat, number needed to harm, false positives, false negatives, those types of things that could end up occurring, and preparing yourself if those end up being the results. How much does it cost? And this one here that I really love, is there a less expensive test that might give the same information? I feel like it's really important to do the exact same thing when it comes to medication treatments. Don and I try to talk about that all the time, and I know our guests bring that up, is what are the alternatives, that come up when there's medical treatment? Sometimes is that lifestyle modifications? It could be. Sometimes could that be another generic medication rather than this prescribed medication plus a lifestyle modification? Oftentimes another kind of component. So, well, amazing, Judith. I really think that now I've got a new resource that I will be tapping into, and I hope the audience does too. But I did want to give you one last, any parting words, Judith, for the audience?
Oh my gosh. Well, I have to go back to Dr. Lown. Do as much as possible for the patient, little as possible to the patient.
I love it. Beautiful. Thank you all for joining. I hope you guys all enjoyed it. I know that I definitely did. And we will see you next time on the Med List.
Thanks.